This talk is about the anatomy of vertical eye movements. The subject of anatomy of vertical eye movements is confusing. It is so because there is lots of maybes and unknowns about the nuclei and the pathways involved in vertical gazing. Nevertheless, it is important to have a model that approximates reality and allows us to make clinical decisions about where the pathology is likely to be in patients presenting with vertical gaze problems. I hope the model I am presenting serves you as well as it has served me for the stated purpose. So now let's start. Looking down and looking up shares many nuclei and pathways, but also differs in many ways. Hence, we will address upgaze and downgaze separately, although at times comments applying to both will be expressed. We will first talk about anatomy of upgaze. Two extraocular muscles move the eyes up. They are the superior rectus and the inferior oblique. Both of these muscles act together and with about equal force when looking straight up from the primary position. The machinery that moves these muscles is in the upper midbrain. Each inferior oblique is innervated by the ipsilateral oculomotor nucleus. The superior recti are innervated from the contralateral oculomotor nuclei. The fibers traveling towards the contralateral superior rectus cross within the oculomotor nucleus. Hence, an unilateral oculomotor lesion will produce bilateral superior rectus palsy. The rostral interstitial medial longitudinal fascicle nucleus, as you can see in the lateral specimen, is located above the red nucleus, just between the midbrain and the diencephalon. The function of this nucleus is to program and generate the signal for vertical gazing. In the case of upgaze, this nucleus excites the oculomotor nuclei to contract the superior recti and inferior obliques. The fibers of the rostral interstitial MLF nucleus decussate at the posterior commissure and after decussating innervate the contralateral and ipsilateral oculomotor nuclei. This pattern of innervation, post-decussation innervation of contralateral and ipsilateral oculomotor nuclei, explains why posterior commissure damage, which permanently deprives of innervation both the ipsilateral and contralateral oculomotor nuclei, produces enduring upgaze palsy, whereas damage limited to one rostral interstitial MLF nucleus after the initial shock that causes upgaze palsy recovers. The reason for this recovery is that the rostral interstitial MLF nucleus that remains healthy takes over the activation of both oculomotor nuclei. Hence, unilateral rostral interstitial MLF nuclear lesion produces transient upgaze palsy most of the time. I have now introduced the interstitial nucleus of Cajal. This nucleus is just below the rostral interstitial MLF nucleus. The interstitial nucleus of Cajal acts as a neural integrator. It incorporates information from multiple sources for two purposes. One purpose is to adjust the amount of contraction of the extraocular muscles required to achieve the appropriate vertical position, and the second one is to keep the eyes in the upgaze position where they should be. It is because of this later action, which by the way is also harbored in this nucleus for downgaze, that the interstitial nucleus of Cajal is considered the hub of the vertical gaze holding system. The interstitial nucleus of Cajal receives fibers from the ipsilateral rostral interstitial MLF nucleus and connects with the ipsilateral oculomotor nucleus and also with the contralateral oculomotor nucleus through the posterior commissure. If you are as old as me, I hope not, you would remember the nucleus of Dark-Shevich. This nucleus used to be considered an important vertical gaze control center. Well, it is no longer considered so. Hence, it will not be mentioned again during this talk. Now let's bring in the medial longitudinal fascicle. The medial longitudinal fascicle is a bi-directional multi-purpose expressway that accommodates fibers going from many places to many other places. Upgaze fibers in this fascicle connect the rostral interstitial MLF nucleus with the ipsilateral and contralateral vestibular nuclei. This crossing is selective. Fibers from the vestibular nuclei that inhibit the superior recti and inferior oblique do not cross the midline, whereas those excitatory do. The upgaze excitatory and inhibitory fibers traveling in the MLF connects the rostral interstitial MLF nucleus specifically with the superior vestibular nucleus. This nucleus is part of the vertical gaze holding system. The vestibular nucleus receives fibers by the 8th cranial nerve from the vestibular apparatus, especially from the anterior semicircular canals. The vestibular nucleus on each side is also connected with the perihypoglossal nuclei. This group of nuclei is also considered part of the vertical gaze holding system. The perihypoglossal nuclei are easily dissected in cats. The perihypoglossal nuclei includes 3 nucleus. The prepositus hypoglossi, which is more involved with the lateral than with the vertical gaze holding system, the nucleus of Roller or subhypoglossal nucleus, and the nucleus intercalatus. In this frame, I have introduced an MRI of the lower posterior fossa. It belongs to a patient that after removal of a cavernoma from the area circumscribed by the interrupted yellow line developed up-pit nystagmus. In it, you can see the prepositus nucleus in red and the intercalatus nucleus in green. So the vertical gaze holding system is constituted by the interstitial nucleus of Cajal, the superior vestibular nucleus, and the perihypoglossal nuclei. The vertical gaze holding system is supported by a constellation of interconnected structures. One of the most important is the nodular floccular lobe. The nodular floccular lobe is interconnected with the vestibular nucleus. In this frame, I have introduced an anterior view of the cerebellum to point out the cerebellar structures involved with the vertical gaze holding system. We have already mentioned the nodule and the flocculus, but we also need to mention the paraflocculus, also known as the tonsils, and the ovula. Another structure involved with the vertical gaze holding system is the inferior olivary nucleus, which connects with the contralateral flocculus and also with the perihypoglossal nuclei. Another structure involved in supporting the vertical gaze holding system is a group of cells in the paramedian tract, which connects with the cerebellum. In addition to the MLF, the ventral tegmental tract and fibers traveling in the brachium conjunctivum, represented in yellow, carry excitatory upgaze fibers connecting the superior vestibular nucleus with the contralateral rostral interstitial MLF nucleus. The cerebral control of upgaze arises from the frontal eye field, likely area 8, and the parietal eye field. The neurons in these fields, either directly or through intermediary structures in the basoganglia and thalamus, transmit the stimulus to the ipsilateral superior colliculus. Nuclei in the superior colliculi relay the signal to the ipsilateral rostral interstitial MLF nucleus. So we have constructed an anatomical model for looking up. Now let's do the same for looking down. In this frame, we can see the eyeballs, muscles, cranial nerve, and cranial nerve nuclei involved in looking down. The oculomotor nucleus innervates the ipsilateral inferior rectus. The cranial nerve 4 nucleus sends fibers that cross the midline in the anterior medullary velum to innervate the contralateral superior oblique. I have now introduced the upper midbrain. The oculomotor nucleus is at the level of the superior colliculus. The nucleus for cranial nerve 4 is at the level of the inferior colliculus. We have now added the rostral interstitial MLF nucleus. As you recall, this nucleus was introduced in the construction of the upgaze model. This nucleus harbors neurons that program and generate signals for up and down gaze. In this frame, I have inserted a figure with tissue corresponding to an unaffected left rostral interstitial MLF nucleus and a right one destroyed by an infarct. The patient had up and down gaze palsy. The patient died before the expected recovery that usually occurs following ipsilateral rostral interstitial MLF nuclear lesion had occurred. The rostral interstitial MLF nuclei send ipsilateral fibers that reach the 3rd and 4th cranial nerve nuclei. So as you can see, the rostral interstitial MLF nucleus downgaze related neurons do not send fibers via the posterior commissure to the contralateral cranial nerve nuclei. That is the reason posterior commissure damage, as occurred with Parinau syndrome, rarely produces downgaze palsy. As you can see, we have now added the interstitial nucleus of Cajal, one on each side. The interstitial nucleus of Cajal, as the rostral interstitial MLF nucleus, harbor neurons with function for down gaze and up gaze. It serves as the hub for the vertical gaze holding system for down and up gaze, as we previously mentioned. The nucleus of Cajal receives fibers from the ipsilateral rostral interstitial MLF nucleus and send ipsilateral and contralateral fibers to the cranial nerve 3 and 4 nuclei. The contralateral fibers decussate at the posterior commissure. We have now added the vestibular apparatus, cranial nerve 8, the vestibular nucleus, and the MLF. As for upgaze, some downgaze fibers cross from one MLF to the other, thus connecting each vestibular nucleus with the rostral interstitial MLF nucleus on the other side and vice versa. It is important to know that the main semicircular canal involved with downgaze is the posterior one. The rest of the machinery for downgaze in the lower brainstem and cerebellum, although maintaining their functional independence, is harbored in the same structures as the upgaze machinery. For example, downgaze holding and upgaze holding system are harbored at the interstitial nucleus of Cajal, as we just previously mentioned, the superior vestibular nucleus, and the perihypoglossal nuclei. Similarly, cerebral structure and connections governing downgaze are anatomically intermingled with those controlling upgaze and also terminate in the superior collicular nuclei. Neurons in the nuclei of the superior colliculi for downgaze connect with similarly minded neurons in the rostral interstitial MLF nucleus. So we have built a model for looking down and looking up. I will now highlight some differences between the up and down gaze system that have great clinical significance. Upgaze only involves the third cranial nerve. Downgaze involves the third and the fourth cranial nerves. Upgaze occurs due to contraction of the superior rectus and inferior oblique. Downgaze is due to contraction of the inferior rectus and superior oblique. Upgaze fibers going from the rostral interstitial MLF nucleus to cranial nerve nuclei travel through the posterior commissure. Downgaze fibers going from the rostral interstitial MLF nucleus to cranial nerve nuclei do not go to the posterior commissure. Upgaze occurred with bilateral excitation of the anterior semicircular canals. Downgaze occurred with bilateral excitation of the posterior semicircular canal, whereas inhibitory projections for up and down gaze do not cross the midline. Excitatory projection for up and down gaze cross the midline. Upgaze has many pathways going from the anterior semicircular canal to the eye muscles, one traveling through the brachium conjunctivum, another one through the MLF, and yet another one through the ventrotegmental tract. Downgaze only has one excitatory pathway going from the posterior semicircular canal to the eye muscles. Why so many tracts are involved in upgaze? Keeping the eye looking at mid-level between up and down, probably because of the effect of gravity and as a consequence of evolution, requires more force pulling them up than pulling them down. Hence, nature created a stronger and more robust system to reflexly move the eye up than to move the eye down. But as it is for a lot of things about vertical eye movement anatomy, who knows? It is up to you to find the correct answers in the future. Thank you very much for your attention.